Hi there, I'm Dr. Richard Burt, a retired professor from Northwestern University. I still hold an appointment at Scripps and still see patients there, but based on some patents we developed with iPS cells, we started a little biotech company called Janani, where we're trying to bring that iPS, it's a different type of stem cell technology, to the patient's bedside. However, I spent about the last 35 years developing a different type of stem cell, the blood or bone marrow stem cell, the hematopoietic stem cell, as a treatment for autoimmune diseases. And we've had a lot of success for a variety of different autoimmune diseases. So today we'll talk about systemic sclerosis and kind of compress 35 years into 15 minutes. But anyway, so this is 35 years of autologous meaning yourself or your own blood stem cell, bone marrow stem cell, but we get it from the blood transplant for systemic sclerosis, which patients often call scleroderma. So I'll use those terms interchangeably. There are other things that can cause scleroderma besides systemic sclerosis, but colloquially, most people interchange those terms. So it's important to know about systemic sclerosis. Like the name says, the skin gets hard, but it's really a multi-system immune-mediated vasculopathy, and you can visualize it in the nail beds if you put a drop of oil and microscope over it, or now you can do it digitally, and you can see changes in the capillaries that become visible. So in A, those are normal capillary bed, and then they start to become distorted in early systemic sclerosis until they're really just totally obliterated in late systemic sclerosis. And that not only occurs in the skin, it occurs in internal organs. So this is a multi-system disease because obviously the blood vessels go everywhere. Now, as a caveat, that we have no patents on this, we have no drug company support. I just developed this. The patients own their own stem cells. So I did it to help people. And for other people, we publish for other centers to be able to do this, but there's no money involved in it. But just to be aware, I am CEO of Janani, an iPS stem cell focused biotech company, but what we're developing there has nothing to do with this. And so there's not a direct conflict. So systemic sclerosis is a multi-organ disease. And of course, the skin gets hard. It's what's right there in front of people. And that can lead to contractures, like you can see where you can't open the fingers in the bottom. And because you get these joint contractures here in the fingers, in the wrist, in the elbows, in the knees, pretty much everywhere. It ended up, for the most part, in the field of rheumatology that deals obviously with joints, but they also get Raynaud's that can lead to ulcers like this, often on the fingertips is where they most usually occur. But again, this is because blood vessels go throughout the body. It's not just in the skin. You can see it here. You get a patulous or dilated esophagus. So you can see where the esophagus here is very dilated. And because of this ischemia and fibrosis, you lose the muscle fibers in the esophagus, so it doesn't move well. But you get a stricture at the base because of the constant regurg. So you can often get GERD and aspirations and problems from that. It does involve the lung with interstitial lung disease, both nonspecific interstitial pneumonitis and usual interstitial pneumonitis. Here's an example of a CT scan. See all this extra whiting out of bronchiolitis, and it can get really, really bad where the lung function is absolutely horrible and you need supplemental oxygen. It can cause renal crisis, this onion skin peeling. You get real high blood pressure and the kidneys fail. It can cause GI bleed from the stomach. This is called a watermelon stomach or GAVE, gastric antrovascular ectasia, meaning the blood vessels are all messed up in here. And they're just under the mucosa of the stomach. And so the acid can cause them to bleed easily. And, you have to be aware of that. And there's special ways you have to look at that before you take them to a transplant and drop their platelet count. Otherwise, they could have a life-threatening bleed. And this GAVE happens intermittently. So you can just look and it's not occurring at that moment. So it's a very intermittent thing. It causes, importantly, a very stiff heart. And so if you do an echo of a scleroderma patient, their systolic function is normal. The heart contracts normally, but diastole, the ability to relax, is impaired. And so an echo can be very misleading. And so you really need to do a cardiac cath with a fluid challenge to bring out that impaired relaxation of the ventricle, and a cardiac MRI. And here's a cardiac MRI, and that's diastolic flattening there, which is a bad sign if there's a bounce when you're watching the video. It's even a worse sign of the diastolic dysfunction. That's very important to take into consideration when you take these people to transplant, because they don't tolerate fever, they don't tolerate fluids, and yet you have to give fluids for a variety of reasons. So you have to be very much aware of that and approach it differently than you approach transplant, a stem cell, hematopoietic transplant that's done for cancer. These are very different. And in fact, you want to use different regimens than are used for cancer. You don't want to use those cancer regimens. They're too toxic. So SSC mortality is worse than lymphoma, which does justify applying HSCT for them, despite the fact that they do have impaired cardiac function. Even if you don't appreciate it on your workup, it's always there. So how do you pick the bad actors? It's diffuse skin involvement, that is a skin score greater than 14. Modified Rodman skin score is what it's called. It's just how easy it is to pinch the skin, or lung involvement. They have a mortality of 10 to 30% at 5 years, which is really high, worse than lymphomas. Again, it kind of depends what article you're reading, and you can be closer to 10% or more towards the 30%. And then the main cause of death, I don't know what to tell you how to answer it on a test. On a test, most people would say it's the lungs, because the lungs get bad. As I showed you the picture, they're on oxygen. But the truth is, they don't really suffocate. They don't drown. What happens is the heart gives out. Now, the heart may give out from pulmonary hypertension, from the lung being bad, or from diastolic dysfunction, from the heart being really stiff because of the fibrosis going on, or pericardial effusion or cardiac tamponade from stiffness of the pericardium causing constriction of the heart. But there's many reasons it gives out. But clearly, there are newer data saying the main cause of death is the heart. But certainly going through a transplant, that would be the main cause of death if you don't know how to properly adjust the regimen and fluid status for these patients. From my perspective, the main cause of death is the heart, and you have to be careful about that, whether you're doing a transplant or not. All right, so our first trial we did using non-myeloablative regimen. What do I mean by non-myeloablative? What I mean is, if we never give stem cells back, they're going to recover bone marrow and hematopoiesis normally. Unlike cancer, where you're trying to kill the cancer cell in the bone marrow, and if you don't give bone marrow back, they don't recover, or you're increasing the dose as high as you can to kill the cancer, and you accept that the bone marrow is killed on the side, and you give the stem cells back so that the patient doesn't die. Here, we just want to target the immune cells, not the bone marrow stem cell. And Cytoxan is very good as in targeting T and B cells. It's often used in treating autoimmune disorders for that reason. And ATG, of course, targets, it's anti-thymocyte globulin, it targets immune cells too. So this is immune specific. Because of the Cytoxan, the counts do drop, but they will recover without stem cells. So the reason we collect the stem cells before giving this regimen is because it'll shorten recovery about 4 or 5 days. And anything you do to shorten that period of neutropenia increases the safety and decreases transfusion needs and decreases infections, which is what you ultimately want. So we did a trial of our regimen versus monthly Cytoxan, and that's because monthly Cytoxan was the standard of care. There's even New England Journal articles on it, and oral or IV. Monthly IV was considered to be better, so we gave the IV. And what we showed here is, because we already had data that transplant would be superior, and when you do a trial, you have to have this concept of equipoise. In other words, one group cannot get a worse treatment. That's not ethical. So what we allowed, if after a year on the cyclophosphamide arm, standard of care, you were worse, you could cross over to transplant. So what we found, here's the HSCT group, and here's their skin score. So the higher the score, the more tight the skin. You can see it just kept improving over a year, whereas in the monthly cyclophosphamide, it didn't improve, and it was worse by 1 year. When we looked at lung function following FVC, in this case, we could see the transplant group actually, even though it was randomized, had slightly worse lung function, but they got much better right after the transplant. And the transplant's a one-time treatment, no more treatment afterwards, whereas the group that was getting the monthly Cytoxan worsened. And that's actually what the literature says. Although Cytoxan was recognized standard of care with this New England Journal publication and so forth, what it says is your lung function worsens, it just doesn't worsen as bad or as fast as a placebo or sugar pill, but it still gets worse. Whereas and that's what happened here. But as what we did, we showed it actually got better. So that was pretty revolutionary, that it actually improved function instead of just slowing decline, which is what was being used to treat people back when we published this in 2011 in Lancet. So you can pull that up, that article. But because at the interim analysis at 1 year, transplant was so much more superior, we allowed people on the transplant arm then, because we want to achieve equipoise, to cross over to transplant. And that's this crossover group here. So they failed, they crossed over, and you can see they got better. The control arm also functioned as its own control and showed we could still get them better. Now, the downside of that is we don't have long-term follow-up. You can't when you have a crossover. But the good side is that in terms of achieving equipoise, not denying a group of patients a superior treatment, we allowed the crossover. All right. So then we continued as a non-randomized trial called ASSIST. And I did that both at my university as well as the University of Sao Paulo, because I had a long history of working with USP, the University of Sao Paulo in Brazil. And when we combined our patients, which was 90 patients, you can see the skin score markedly improved going out to 5 years, and pulmonary function, FVC, got better. Again, it did what no other treatment had ever done. The problem was there was 6% cardiac-related mortality. So there was an upfront mortality, but then everything got better. And I have patients now that are, more than 20 years out that got better, stayed better, still doing good. But that mortality really bothered me. Now that's less than the 10 to 30% mortality in 5 years expected. And when the Europeans did a study where they didn't cross over and they showed that the mortality ended up less than the transplant arm. But again, there was this problem of early mortality that I wanted to get rid of. And where does that early mortality come from? It comes because the heart is bad. And the problem is cytoxin's cardiotoxic. And you're taking a bad heart and causing a temporary worsening. It does recover with time, but it might be lethal during that process. And the other thing is fluids. What people don't understand is that normal saline, which is hung and given to patients all the time, can kill someone. And any person with a stiff heart, it can kill because the fluid will back up in the lungs and then everything falls apart. And that can happen with an amyloid heart. It can happen with a scleroderma heart. The other is, you got to remember, I showed you the Raynaud's. The capillaries are bad. There's problems with vasoconstriction. So once they get fluid and they start backing up in their lungs and their pressure is low, it's very common for people at the hospitals, they go to the unit, they put them on the drips, these pressors like phenylephrine. Well, there's a black label warning on phenylephrine not to use it in someone who has Raynaud's. It says that as a black label because it causes severe exacerbation, and you end up actually doing much more harm for the patient and hastening the cardiac death. It's a big mistake. Levofed's also a bad one, and fever's bad. So you've got to block fever. It's usually not infection related, and there's ways to block that. But Enbrel, for example, is excellent at blocking the fever. And instead of using Levofed or phenylephrine, it's counterintuitive, but you have to use dobutamine because that causes vasodilation, because these patients clamp down in the periphery and they'll actually end up with a high output failure and a little bit of dopamine to get them through it. And that'll work, but it's so counterintuitive to people in the unit. And the better thing is not to get in that position with your patient. So I want to give you an example. A night resident was called to see a patient day +3, blood pressure 85/90, pulse 100, 110, neutropenia. So of course, the resident said, well, this is sepsis. They intubated, ramped up the fluid, started phenylephrine. So go-to drug for unit people. But that was exactly the wrong thing to do, because a lot of these patients, remember, this is a cardiovascular problem, and many of the patients come in, that's their baseline. And that was this patient's baseline. Normally, very tachycardic, up to 110, and a blood pressure walking in 85/90, and they're used to it. So this was normal for that patient. And they, by giving the fluids phenylephrine, caused a total myocardial infarct. There was no coronary artery disease, but they caused severe vasospasm of coronary arteries. And these patients have a proclivity towards vasospasm to begin with. That's why they get the fibrotic skin and joint contractures and other problems. There was no infection. So, again, it was done not understanding this disease or what's going on with them. And unfortunately, the on-call people didn't talk to the attending of care. So that's one of the problems then in modern medicine is continuity of care is generally not recognized by administrators as important. And of course, now doctors want their free time. I understand why, but that can cause tremendous problems in patient care. And so you can't change a bureaucracy, but you can change a protocol. And that's what I did. So I've got to do these safer. It's phenomenally great therapy, but you've got to do it safer. So I designed the cardiac safe regimen, CAS regimen, where I decrease the cytoxin, which can temporarily compromise hearts that are already impaired. In a normal heart, if you actually do an echo on this type of regimen, you might see a small drop of 3, 4, 5% ejection fraction, and then it recovers. It's totally normal, and there's no long-term problem. But in these scleroderma patients where they're very compromised, it could tip them over. So I decreased it from 200 to 60. I used the same dose of ATG, a total of 6 milligrams per kilogram divided over 5 days. And I added rituximab, and then on the day of graft IVIG. And probably not enough time to explain why I did that, but here's the regimen. And it actually ended up taking my most difficult transplant and making it the easiest to go through. It got rid of that cardiac toxicity. And so it really totally changed these patients. We did 28 patients that way. The survival at 1 year was 96%. One died because the patient had coronary artery disease, and I wasn't going to do it unless they corrected the coronary artery disease, but he refused that. He absolutely refused. We got cardiology involved. We sat and had a long conversation with him. He absolutely refused. So we decided to take him through. It was a big mistake. And so, again, I can't let patients direct my therapy, either deny the treatment if they don't get what was a marginal occlusion of the coronary artery corrected, because during transplant, it's no longer marginal. But most of these patients don't have coronary artery disease. It's functional impairment of the heart itself that's the issue. But anyway, they engraft day 5. So the other regimen, they engraft day 9 or 10. RBCs transfused, about 2 units, platelets, half a unit per patient. That means, many patients didn't even get a platelet transfusion. And for the most part, they're bored walking around, which is really great. But yet we saw the FVC improve at 1 year. This was improvement from 56 to 65. And the skin tightness improved, that is decrease, in 1 year too. Now, the problem was I don't have longer term follow-up on those patients. Caveat, this is one-term follow-up, but it's so much safer that when we first did this, and we did this in 28 patients that we would have normally excluded based on a cardiac cath with fluid challenge or cardiac MRI and an echo, we would have excluded them from going to transplant. So we put them on this safe regimen, and they did phenomenally well. So this has subsequently become my go-to standard of care for these patients. But again, the caveat is we don't have long-term follow-up. So where's the current and future of HSCT for systemic sclerosis? Well, obviously, somehow need to get long-term follow-up from the two. This is the 200 milligrams per kilogram. This is 60 milligrams per kilogram, but added fludarabine, rituximab. They both have ATG, and see how they do. But I currently treat with just the CAS regimen. The 1 year results are phenomenal. It's such a safer regimen to go through. And again, worst thing can ever happen is to lose a patient. And so the future is going to depend on the long-term results of these regimens versus CAR-Ts, which are kind of a new exciting therapy. So what I want to show you is this the ASSIST regimen. It is a lymphodepletion. It's about total mobilization transplant dose, 9 grams per meter squared. So 2 meters squared person, 18 grams. The CAST is much lower dose, 4 grams per meter squared, because we do mobilize still with the 2 grams per meter squared. And then 60 milligrams per kilogram during transplant is about 4 grams per meter squared. Fludarabine 120 per meter squared, ATG 60, rituximab, IVIG. The difference in cost, this is much cheaper. Again, they engraft and are out by day 5. They're around day 10. And the CAR-T, you got to remember CAR-Ts have lymphodepletion. Cytoxin is around 1 gram per meter squared. Fludarabine 75. So that compare that to the CAS. The CAR Ts against just B cells, Rituxan get B cells. There's no T cell directed therapy that the ATG would get. ATG gets T and B and some plasma cells. But the question about CAR Ts, and a lot of people are going to it, is there's a lot of details in how they do this, because they actually insert a retrovirus permanently into the DNA of patients that get these CAR T cells back. And, the question is, could that cause mutation by integrating into the wrong place? And these HIV, it is an HIV lentivirus that is used by most places, by the majority. But, that integrates into open transcribed areas of DNA, not genes that are shut off. So there's always a danger of it contributing to a mutation, an anti-oncogene setting the stage for later cancer, or actually activating an oncogene facilitating an earlier problem with cancer. So there's always that concern. It's going to be long-term follow-up. Now, the overall, they're getting reports of cancers after transplant for malignancies using CAR T. Again, these are patients' T cells that are genetically modified with this retrovirus vector inserted in permanently into the DNA to make the CAR T receptor. But they're getting at 2 years about 2.9% cancers, and at 5 years, 7% cancers. That's the average across the board, which is a very high amount. Now, you can argue, well, these are already lymphoma patients or ALL or whatever, and it's a B cell malignancy they're targeting. And so prior chemotherapy did this, and that's possible. But one thing that's also possible is, besides insertional mutagenesis, is that these CAR T cells, although they do connect to B cells and induce apoptosis of the B cell, they do it by releasing vesicles, and these vesicles that induce the apoptosis, they don't directly target the B cell, and a surrounding cell can have a bystander effect and be damaged. So if there's a surrounding stem cell close to where these B cells are aggregated, there could be collateral damage of innocent stem cells that may result in late cancer. So I think what's going on here is going to take time and long-term comparison of these approaches. But again, the charge here is $500,000 to $1 million US charge. So I think one of the things we have to appreciate in medicine that's kind of been lost in our training is that we not only want to focus on the physical and mental health of our patient, but their financial health. And if the patient itself isn't paying, of our society, because if the society goes bankrupt, there's less people that can be treated overall in that society or by that insurance company. So those are things that'll have to just take time to sort themselves out. But that, I think, is the future. And I wanted to refer everyone to this book, Everyday Miracles. The forwards by the Dalai Lama is kind of a kitchen soup for the soul. And these are patient stories with autoimmune diseases, what was going on with all this drug therapy with them and how they were only getting worse. And then after transplant, how they got so much better and needed no more drugs. So you will, I think, really enjoy that. And then finally, I also want to show you this book. It's called Kill Switch. And well, Everyday Miracles is kind of the take-home point is that as physicians, we need to also accept financial responsibility in terms of cost effectiveness of our therapy for patients and for society. That's kind of been lost in our training. But then also in Kill Switch here, it's respect for the individual is the ultimate endpoint on this. You're going to find this super, super interesting. This one, the forwards by the Vatican. And also that's an ecclesiastical forward. And the forward is also by Senator, U.S. Senator from the state of Illinois. Now, again, I highly recommend both those books to the audience. I think you'll really learn a lot that has not been said. Thank you.